Thank you, Raghu. Good afternoon to all of you. So my remit today is to highlight the various aspects of lid reconstruction in the setting of trauma. I shall elaborate on the acute management of a patient with injury to the eyelids, goals and principles of lid reconstruction, some of which have already been discussed, and finally the management of lid lacerations or lid trauma with or without lid defects. So what is different in lid reconstruction in the context of trauma is commonly the presentation is quite acute and you're faced with a distressed patient with a surgeon who is faced with a challenging situation, frequently out of hours. There may be associated life-threatening or sight-threatening injuries, presence of possible foreign bodies or orbital involvement. And what is required in this situation is prioritization, a systematic approach, often liaising with your colleagues in other specialties with an emphasis on quick decision-making in that situation. Approaching an acutely injured eyelid, the first steps are, as mentioned, exclude life-threatening injuries, presence of globe injury or orbital involvement. A thorough history allows you to find out the mode of injury and suspect foreign bodies. In that situation, keep a low threshold for imaging, which is in most cases a CT scan. Some cases, more complex ones and those involving critical structures may need general anesthetic, and appropriate arrangements need to be made for that, apart from tetanus prophylaxis and antibiotics. And this is a good time to take a clinical photograph if possible. Adnexal examination begins with evaluating the extent of the injury, the depth, the presence of any infection or grossly devitalized tissues, any foreign bodies, involvement of the lacrimal system, orbital involvement, and most importantly, any lag of thalamus or exposure of the globe. Timing of repair is generally best done within the first 24 hours of primary repair. Sometimes you may have to delay it by a few days to control infection or inflammation, and secondary repair is generally poorer in its outcome. Injuries without tissue loss may either be margin sparing, margin involving, or sometimes classified as simple ones or more complex lacerations. Simple margin sparing lacerations can be closed in layers as shown here, with an emphasis on eversion of the wound edges and use of interrupted sutures. More complex lacerations may require the wounds to be brought back in position, aligning them as best as possible with anatomical landmarks. The classic technique for repair of a lid margin laceration involves the use of 3 non-absorbable 6/0 sutures, classically placed in this fashion through the posterior lid margin, the gray line, and the anterior lid margin, with further repair done, and the tails of the margin sutures tucked into the anterior sutures. An alternative in this regard is the diagonal suture lid margin repair, using a single absorbable 6/0 vicryl suture, which is passed from the about 3 millimeters inferior or away from the anterior tarsal surface, and the needle then comes out at the posterior lid margin and then engages the posterior lid margin again on the opposite side with a mirrored site of exit. This is a video showing the same technique. This is courtesy my colleague, Mr. Richard Caesar. This is the site of entry of the needle antero-inferiorly for the lower eyelid, coming out at the posterior lid margin, and then going back into the posterior lid margin at the supero-posterior aspect of the tarsal plate. And finally, this brings the two ends together, and further repair of the tarsal plate and the wound is done in layers. This avoids suture abrading the surface of the eye and is superior in that sense. Associated levator disinsertion or injury should be looked for, particularly if you find fat within the wound, which is an indication of septal damage. Associated canthal tendon injuries need to be repaired at the same time, if possible. Sometimes very innocuous looking wounds may harbor quite sinister foreign bodies in the orbit, and when in doubt, always image. In this case, this was part of an e-cigarette or a vape which was removed from the orbit. Canalicular injuries commonly are suspected when there is a full thickness lid margin laceration medial to the punctum, and the lower canaliculus is more commonly injured. Early repair is desirable, and delayed repair till 5 days is acceptable. This is an example of the same. Lid margin laceration, exposure and identification of the distal cut end, and repair with mini Monoca stent, end-to-end apposition of the canalicular ends, and a repair of the lid margin repair, resulting in a good outcome. Finally, the reconstruction of lid trauma with tissue loss or lid defects is similar to the reconstruction with, from other etiologies, as has been already covered by my colleague. So the principles remain the same. With non-marginal anterior lamellar defects, it's preferable to convert them into an ellipse as far as possible and respecting Langer's lines. An alternative that has been described is the magic suture proposed by Thaler and Vadani, which essentially is a deep subcutaneous suture, bringing the edges, the wound edges closer together, with an emphasis on the direction of suture to be parallel to the lid margin at all points, as shown in the diagram here. And with this technique, they propose, they have shown reasonably large defects to be made quite much smaller and amenable to closure. An alternative is always full thickness skin graft. And when nothing works, just leave it to nature and using the laissez-faire approach. This is a picture showing areas on the face which are most amenable to a laissez-faire approach, with the green areas being most favorable. Small full thickness defects can be closed by direct closure, technique of which has been discussed, further augmented with a lateral canthotomy and cantholysis. Another example of the same. Moderate full thickness defects require techniques such as Tenzel's or McGregor's advancement flaps, apart from other combination of other flaps and grafts. This has already been covered before. The Tenzel's advancement flap, a myocutaneous flap which allows for closure of a moderate lower lid defect. An alternative to that is the McGregor's flap, which involves a Z-plasty to effect tissue lengthening along the lid margin. Larger defects, near total full thickness defects, generally employ lid sharing procedures apart from non-sharing procedures, which my colleague shall probably emphasize on. This is a pictorial description of the Cutler-Baird procedure, which is employed for an upper lid defect using a flap from the lower lid. This is an example of the same, a defect in the upper lid. Posterior advancement flap accompanied by a middle lamellar graft, which in this case was banked sclera. Completion of the graft, of the flap, and then finally post-division. A similar flap for lower lid defects would be a Hughes flap. Example of a defect in the lower lid, closed with a Hughes flap, and the picture post-division. Example of another Hughes with anterior lamella being repaired with full thickness skin graft instead. At times, one is faced with rather challenging situations, as was in this case with a lady who fell unconscious in her kitchen and apparently fell over her dog, who then proceeded to attack her and bit off most of her face, including the nose, the upper lips, but more importantly, resulted in a situation with complete loss of the upper and the lower lids, resulting in challenging situation for repair, but also something that needed quick temporizing measure to cover the globe. What I used in this situation was the masquerade procedure, wherein Fornical conjunctiva was identified and drawn towards the midline, sutured in the midline, and then advancement flaps from the forehead and the cheek was advanced to cover the entire globe, thus protecting the globe. And then a second procedure done a few weeks later to create a small slit opening, thus allowing the lady use of her eye, although a small amount of phimosis has happened subsequently, which needed further repair. But she retains good use of the eye and is 6/6 in the eye. So to summarize, in adnexal trauma, having a stepwise systematic approach and being able to prioritize appropriately is key. Keep a watch for lacrimal system injuries and foreign bodies to make sure you don't miss those. Following the basics, which have already been described earlier, of flaps and grafts is essential. And sometimes, particularly in cases of trauma, use techniques to protect the globe and temporize if needed. Thank you for your attention.
Thank you so much, Prashant. That was really very enlightening. And excellent overview over all the intricacies of traumatology in our field. And now I would like to introduce Dr. Raghuraj Hegde. I got it wrong. Hegde, sorry. From Manipal Hospitals, Bangalore, who is going to talk about medial canthal deformities and their management. Thank you.
Yeah. Hi. So I'm going to be speaking about medial canthal deformities. So some of the medial canthal defects, reconstructions has been covered by Yaj already. So I won't be doing that. So basically, medial canthal deformities are one of the most challenging cases that we have in oculoplasty, because the blood supply is a little restricted and the scarring is more in the medial canthus. And so in this presentation, I will be speaking congenital anomalies and trauma. So the other, because cancer reconstruction has already been covered. So clinical significance, so basically the impact of the eyelid alignment and function, and also the effects of the tear films. So tear film distribution and drainage is indicative of how the medial canthus is, and the position of the medial canthus is very important for the tear drainage as well. And aesthetic considerations also, because it is right at the eye, it is sometimes quite dystopic. Medial canthus will have effect on the cosmesis as well. So just brief anatomy. So we have to be mindful on the medial canthus that there is a lacrimal sac at the medial canthus, and on either side of it there are two crusts of the medial canthal ligament. So this is very important, as we'll see in the other future slides, that this is very important to keep in mind while we are reconstructing these medial canthal abnormalities. So congenital medial canthal, the biggest one is that blepharophimosis syndrome. So this is a lady, just to demonstrate, I'll just give you a brief history of a 26-year-old lady with telecanthus, epicanthus inversus, ptosis and uriblepharon. So the purpose of this presentation, I will only be speaking about the telecanthus part of it. So I have adopted this technique developed by Kim Yoon Duck. So she's basically, there is no VY-plasties that we've been formerly using. We've been using this medial epicanthaloplasty using a skin redraping method. And this paper is very important because this is the general theme of the whole presentation, where I use the same technique in trauma as well, post-trauma defects as well. So, so the surgery where basically we reduce the telecanthic distance with using and we refix the medial canthus to the medial canthal where we are supposed to have the medial canthal ligament. So the medial canthus is fixed, and then you can see that the caruncular is exposed, and you can see that the fold of the medial canthus is also has disappeared. So subsequently she had a second stage procedure for a ptosis correction as well. So this is how this medial canthal was reconstructed. So medial canthal injuries, very common, we see it all the time. We often see it with the setting of a canalicular injury as well. So in this particular case, it was quite challenging initially because all the tissues were macerated at the beginning, and then we finally found that she had like a double injury at the canaliculus. So the initial laceration was right at the puncta. So that makes it more and more challenging to keep a monocanalicular stent. So we did the procedure, did it as best as possible, but the patient came back with this medial canthal defect at right at the canthus, and we can see right at the canaliculus. So you can see that I'm not sure if you're able to appreciate that there is a monocanalicular stent sticking out of the canaliculus right there. So basically there was some vertical pressure going down, as well as the vectors were going down, as well as because of the wound tension, it was getting pulled off. So what we did was a multiple Z-plasties, and then also a lateral canthotomy cantholysis to release the eyelid to the medial side. Then we did a DCR in the same setting, because that would we would be able to put a bicanalicular stenting, and that would help in keeping the medial canthus at the right position. So sometimes we have very complicated trauma in the upper and lower canaliculars, or both are lacerated. So in these cases, I prefer to do a DCR at in the primary setting. So along with the reconstruction, because that aligns the eyelids in the correct positions, and also the force with the intubation actually pushes the canaliculus at the puncta right towards the medial canthus. So that's a good pressure to have. So we do a DCR at the same setting, and this is at the end of the case, and he healed up quite well. We of course did a lot of scar management post surgery as well, which I will be speaking about. Scar management I will speak about in my last talk of the course. Sometimes, so this is another case, but it had a little bit of different course as it went. So we did the same. Both the canaliculi were lacerated, and there was a big injury at the medial canthus. So we did a DCR at the same sitting, and we put a bicanalicular intubation. Immediately post surgery, she was fine. She was doing well, and her epiphora, there was not much epiphora, all that was not there. But about a year later, she turned up in my clinic saying that she's having tearing, and on closer examination we saw that there's a medial ectropion, and so that medial ectropion there's pulling of tears in that medial ectropion, and basically there is a skin shortage as well in the anterior lamella. So what we did is I redid the DCR, because she was having blockage as well. So when we did the DCR, and we put the medial canthus in the position, and then there was a defect at the lower lid. So when the defect was, basically we reconstructed it with the advancement flap from the lateral lid. And so this is how it was, and post surgery her epiphora was resolved. It's not perfect, but at least functionally she is happy with it. This is another medial canthal injury, dog bite. So in our part of the country, we get a lot of dog bites, especially in small kids. So this is during the COVID time. So we went in for an emergency surgery. There was a big hematoma at the medial canthus. So I drained the hematoma, did the primary suturing. So at that time I was not sure, because of all the edema, we could not see where if the medial canthal detachment had occurred. The patient was lost to follow because there was a COVID-19 pandemic going on at the time, and the patient next presented 2 months later with epiphora and mucus discharge coming from that the right eye. And on CT scan we could see that there was a mucocele that was forming. So basically the initial injury had damaged the NLD as well. So that was the reason for. So I used the same technique that we use for blepharophimosis with this skin redraping method. So we use the same incision to do a DCR as well. So this is so we go ahead and do a DCR at the same incision with the subciliary incision. It's much easier in kids because the distances between the subciliary incision and the sac is quite small. So we do the DCR, and then I reattached the medial canthus back into position, and this is at the end of it. She healed quite well with the medial canthus back in position, and also the epiphora was also resolved. So another complex candidate, which again a dog bite injury, a 10-year-old girl who came. So she had a lower canalicular injury. So I did not go ahead with any DCR at that time because the upper canaliculus was fine, and I could feel that I could retrieve the dye from the under the inflameatus. So the sac and the NLD was normal. So we did a monocanalicular stenting and repair of all the skin and eyelid wounds at the same time, and so this is there was eyelid margin tear. So we did the suturing, and post surgery she came with a dystopia. So she didn't complain of tearing, but she complained of this dystopia, and that it was quite, you can see that it is not in line. So it's not at the same line. So what we did was similar to what was done, but here we didn't do a DCR. We just did the medial canthal fixation to the medial canthus, and we use the same subciliary incision and supraciliary incision, the vive-shaped incision. So the scarring is much lesser and is aesthetically more pleasing. So so we reattached it back, and then this is at the end of the case, and so post surgery you can see that the canthus is back in position, and the red line shows that it's back in position. Of course, we did a lot of scar management with 5FU injections and the scar creams like silicone gels. So in summary, medial canthal deformities can be varied in presentation. It can be congenital, traumatic, and like post cancer as well. And meticulous planning and preoperatively planning it is very important, and also sometimes we have to take some decisions on table, and identifying the anatomical landmarks and knowing the anatomy is very important. Knowing where the medial where the anterior crux and the posterior crux is there, where the lacrimal sac is there, that awareness is very important. And some of these cases we need to do multiple surgeries. There is scarring and vascularity and infections post surgery, so we have to be very careful, especially dog bites. The infections is a big problem, and patient expectations needs to be better managed. Thank you.
So hello, welcome everyone. I will be speaking about the, oh, sorry, you wanted to say something.
Hello, yeah, sorry. Now Dr. Meghna Varde will speak about reconstructing the missing pieces, eyelid reconstruction and congenital eyelid deformities. So she is a consultant at Cantonal Hospital St. Gallen in Switzerland.
Thank you. And thanks for inviting me for this nice instruction course. So I'm having the pleasure about talking about reconstruction in congenital eyelid deformities, and my job has become much easier with the people who were presenting before me, so I don't really have to go into details much. I don't have any financial disclosures, and I would recommend you not to take any photographs, because otherwise the lion will come. So congenital eyelid deformities can be classified into four pieces. So there are abnormalities of eyelid division, tissue defects, malpositions, and lesions, which can present at birth or soon after birth. So what do we as oculoplastic surgeons do? This is an image of painting a face with your eyes. So what we see over here, can I have the pointer? So what we can see over here is actually that the periocular area is the one that is most important when we look at somebody else's face. So what we are doing is not only aesthetics and functional, but we are also actually doing a rehabilitation for the patient to work and to function in his normal habitat. So in congenital deformities, it's always about the indication and timing of surgical correction. So you need to see what is your aim of the surgery, whether it's clearing of the visual axis, maintaining the integrity of the ocular surface, or cosmetic rehabilitation, as I have said. So like that, the surgical correction can be planned, sometimes necessary in the neonatal period, if there is really a problem in the ocular surface. 6 weeks is a time when mostly the kids are more ready to be taken up for general anesthesia, as well as 6 months or at 5,000 grams of weight. Then at 2 years, when the facial features and the facial skeleton is actually developed, or 4 to 5 years before the initiation of school, if it can wait that long. And then as a teenage or as an adult, if you want to do a correction, when the patient is able to endure a local anesthesia and comply for the surgery. So I just want to firmly touch on the embryology of the eyelids. It starts after the first month with the lens vesicle developing and the surface ectoderm invaginating on top of it, then forming 2 folds of surface ectoderm, which is basically driven by the mesoderm, which is pushing it forward. At 5 weeks, I can't really. Okay. At around 5 weeks, there is a complete fusion of the eyelids, and that time, 8 weeks to 5 months, and that time is actually used for the eyelid development, of developing all the eyelid structures, the adnexal structures that we know in the eyelid, and also for deforming the anterior segment of the eye. So eyelid separation happens just 5 to 7 months, at 5 to 7 months, which is just before birth. So in this time, there is a possibility of developmental eyelid malformations, which is mainly failure in development of the folds, which can lead to any form of cryptophthalmus, failure of the separation of the eyelids, which can lead to any form of angular blepharon, and interruption of the eyelid folds, which can lead to any form of coloboma. There are lots of systemic associations with cryptophthalmus. These are the 3 main associations. They are mostly epidermic malformations, which can be mainly the face, or it can also develop, or it can also incorporate heart problems, genitourinary malformations such as imperforate anus, and subglottic stenosis, which can also be life-threatening. So these 3 are Fraser syndrome, Mota syndrome, Manitoba being a place in Canada, as I've read, and ablepharon macrostomia syndrome. There are a few other syndromes also associated with it. Many of them are autosomal dominant inheritance pattern. So do we need to look for associated syndromes and genetic disorders in cryptophthalmus, which we all know is always very intensive in investigations? So this is a very recent paper from the Katowice group from 2023. And they've looked at ocular malformations and underlying systemic disorders, and they've identified in nearly all cases of unilateral and bilateral cryptophthalmus that there was something associated. So they are actually presuming, or they are advising, that a comprehensive genetic evaluation should be done for all children with unilateral or bilateral cryptophthalmus. There is another interesting paper which has come out recently, ophthalmic features and management of 86 patients, which are about 112, I think, cases, to assist in surgical planning in cryptophthalmus. So depending on the visual potential which they have found in these kids, depending on the electroretinogram VEP, if the visual potential is there, the integrity and protection of the globe, of course, is to be prioritized, which also reflects in your management of the case. So in this paper, they have they have classified cryptophthalmus into complete, incomplete, and abortive, and I'm going to give you examples to each one of them. So these are two examples of complete cryptophthalmus. This is one from the Pediatric Oculoplastic Surgery book. This is one from this paper, where you can see that there is a smooth surface of skin overlying the eye, completely from the forehead going to the cheeks. And in this case, they did a complete reconstruction of the anterior segment as well of the lids, which unfortunately didn't give the patient any benefit. This was done after ERG, of course, and VEP, and thinking that there is visual potential. And in this case, actually, they also saw that there might be visual potential. They did basically the same thing, and apparently this patient is having ambulatory vision. So not all is lost in these very bad cases. In a case like this, cryptophthalmus can be associated with microphthalmus and with microphthalmus with cyst. And in this case, it's bilateral, but asymmetric. So they have actually, with the cystic globe, which doesn't have any visual potential, there is a potential of cosmetic rehabilitation. So the authors hypothesized that until the age of 7, there should be a cyst reduction done, because the cyst in itself is actually also helping in skeletal growth and growth of the orbit. From age 7, you can actually excise the cyst, put an implant, and we can discuss about whether it has to be a hydroxyapatite implant. And a socket reconstruction can be done with mucous membrane grafting and local flaps for it to be able to hold a prosthesis. So these are pictures from my fellowship of incomplete cryptophthalmus. Incomplete cryptophthalmus actually having a lesser degree of visual potential, as in this child, and always having a fusion of the upper eyelid towards the ocular surface. So there are different options of reconstruction. Again, for the posterior lamella, mucous membrane can be used. Amniotic membrane can be used. Canthal suspension with a tassel strip or a periosteal flap. And for the anterior lamella, flaps, grafts, and tissue expansion has been discussed by my previous colleagues. This is a case of abortive cryptophthalmus. This is the least severe of the cryptophthalmus cases. There is a mild, moderate, and severe form. So this might be a severe form of cryptophthalmus with adhesion of the upper lid also to the ocular surface, but the ocular surface being able to be reconstructed, as in this case. So Dr. Subramanian had used a switch flap from the lower lid to reconstruct the lid, as well as PK has been done. Unfortunately, I don't remember what the vision in this eye was at the end of the surgery. So the mild cases of cryptophthalmus, of abortive cryptophthalmus, cannot really be differentiated from eyelid coloboma, which can also be due to failure of migration of ectoderm, mainly because of amniotic bands or any kind of other systemic associations which we will see. Most often, the upper eyelid is involved. The syndromic associations which we have to keep in mind is the Charge syndrome, coloboma, heart defects, choanal atresia, and genital abnormalities, and Goldenhaar syndrome. Management involves most of the time director positioning, as in this case. Sometimes you can use a lateral canthalysis, which was not required. There is another syndrome called Treacher-Collins syndrome. It's a dysmorphosis syndrome, which has a pseudocoloboma of the lower lid, and the reconstruction is mainly with a switch flap from the upper lid. This is a case of ankyloblepharon filiform adnatum, and actually the surgical management is very straightforward with just cutting of these filiform adhesions. But one has to keep in mind that in type 3 and in type 4, there might be syndromic associations which can actually also be life-threatening. Can I come to craniofacial cleft? So it's just a little bit. So about craniofacial clefts, there is a failure of fusion of the facial prominences and a failure of mesodermal penetration. Most of the cases are sporadic. And there is a classification by Tessier about craniofacial clefts, some of them involving the eyelids, the lower lid and the upper lid, and some of them also, number 3, number 4, involving the nasolacrimal system. So in these cases, many a times, switch flap techniques can be used, and the medial canthal reconstruction, just like Dr. Hegde had told us about. So this is one of the cases that we had. I think I will skip the lid malformations in this case. Epicanthus has been already addressed. And just for the nevus, I just wanted to say that there is only a very slight chance of malignant transformation. The reconstruction after excision, if wanted for cosmetic reasons, can be done by the normal ways. So as a takeaway message, the abnormalities in the fusion and division process will lead to eyelid division defects, tissue defects, malpositions, and can also lead to lesions. Associated syndromic manifestations have to be found. Reconstructions will follow in the same lines as we know, and the timing of surgery needs to be taken in account. Conservative measures can be used in most cases for buying some time. Thank you.
Thanks, Meghna, for illustrating the entire spectrum of pediatric congenital anomalies so well. The next speaker is Raghuraj Hegde, and he will be speaking on optimizing outcomes and revising suboptimal eyelid reconstructions.
Yeah, thank you, Prashant. So thanks everyone for staying back. I know lunch is waiting, but I'll finish this presentation quickly, and we'll have a small panel discussion. Please stay back for that. So surgeons from different specialties attempt oral fractures and plastic, like all the plastic surgeons and ENT and maxillofacial, they attempt eyelid surgeries which are not, which often have suboptimal outcomes aesthetically as well as functionally. So there's a lack of availability of oculoplastic surgeons in trauma centers. So that is the most common reason why we have suboptimal outcomes in the first place. So, and also there's a lack of credentialing process in India as well. There's no legal limitation for any surgeon to attempt any surgery, and there's again a very poor accountability for outcomes. And training in fundamental concepts in facial trauma are lacking in India, not just in ophthalmology, but across specialties. So what keeps me in business in Bangalore is basically dog bites, like I mentioned in my previous presentation, and now as well as road traffic accidents where people have very high risk behavior in Bangalore. So they drive without helmets and drive multiple two-wheelers. So this is what keeps me. And another reason why I'm in business is because many of these patients are treated by plastic surgeons and maxillofacial surgeons. So in this case, a plastic surgeon repaired an eyelid without even seeing if the canaliculus is repaired or not, and it's caused a very bad eyelid scar, and we had to go and revise that patient, and there was a ptosis as well. The levator also had to be reattached. All those things were not taken care of by the primary surgeon. So then we have this lacerations, canalicular lacerations, eyelid lacerations with using staples. So really it is very, very disturbing to see staples on the eyelid. So it's, of course, we have to do canalicular stenting, but we should not put staples on the face. I'll be speaking a few slides on scar modulation because it's very important in these kind of cases where we do use scar modulation. My treatment of choice is 5-FU, 5-fluorouracil, and it has shown significant capacity of modulation in the scar following trauma, whether it is primary trauma or secondary trauma. It is proposed mechanism of action is through the inhibition of the rapidly proliferating fibroblasts, and it results in decreasing collagen deposition and scarring. It's still off-label, but there is enough evidence now that it really works. And what I generally use is a scar cocktail. It's a 9:1 ratio of 5-FU and triamcinolone acetonide. I always give it perilesionally, not into the scar, because it will cause epithelial defects. So, and it's best administered, what we use is a rule of 3, best used between 3 weeks to 3 months of the wound repair. And we can give it weekly or bi-weekly. Usually within 2 injections you start seeing the effect. If it is enough, we can stop at that, and then we can go up to 10 or 12 as well. So there is hardly any side effects with use of 5-FU. So a particular case that was the primary repair was done by me, but you can see that it's all macerated, and the scarring, the epithelial scarring is very high. So when after 4 weeks, there was a big scar at the eyebrow, and we started him on 5-fluorouracil, and after another 4 weeks of weekly injections, so the scar was well modulated, and we can see that at least the eyebrow, even though it's thinner, but at least it is in line, and there is no hypertrophic scar on the eyebrow. So scar massage, silicone sheets are, but it's quite impractical for a eyelid or a face scars. So what I usually use is a silicone gel, and with scar massage. The scar massage is very important. More than what material we use, the massage is the important part. So sometimes I even tell patients who are not able to get this properly, even coconut oil or Vaseline jelly is also enough to do the massaging. So just to highlight the kind of cases that we get, the 6-year-old who had dog bite and with tissue loss 3 years ago, multiple surgeries by multiple plastic surgeons. There was an upper lid graft which was rubbing on the cornea while she was closing, and she also had a severe lag of ophthalmos as well. So in this case, because of multiple surgeries, we couldn't do any lid sharing procedures from the skin side. So what I did was I removed the skin graft and separated it from the posterior lamella, and after exposing the levator palpebris superioris, so then I took a Hughes flap kind of thing and attached it to the levator palpebris superior directly, and then after some undermining, there was still a defect left. So I used a post-auricular graft to close the residual defect there, and after 4 weeks we divided it, and now even though it doesn't look that drastically different, now she doesn't have any, there's the entropion, that was cicatrization entropion that was there, which was rubbing the cornea, is now completely gone, and even her lag of ophthalmos also improved quite significantly. So another dog bite about 2 years ago, operated by a maxillofacial surgeon. They were just suturing without any putting the pieces back together. So then he had a very bad scar running along his forehead, which is extending into the eyelid. So there was a severe lag of ophthalmos as well when he's closing. So he was having a lot of irritation of the eyelid. So what we did was basically I was more concentrating on the eyelid in the first in the surgery. So basically I separated the scar, and this was such a big defect there, and after some undermining and using a post-auricular graft, we managed to put a free skin graft and repaired it, and of course we did some scar management, but after first surgery still there was a significant superior vector which was pulling the eyelid up, and the scar at the eyebrow had to be seen, and also the alignment of the eyebrow also was wrong. So then we went in again with for another second surgery, where we had to I excised the whole scar along the forehead, and then realigned the eyebrows back to where it was. Still, and because it was a forehead flap, we could close it fairly well, but there was still a defect that was there. So that defect was we used a post-auricular graft on the other side to close that defect, so that we could we could finish the anterior lamellar reconstruction. So this is how he presented to us, and this is how he was at the end of the scar treatment, as well as multiple 5FU injections as well. So his lack of thalmus is much better, and now there's a good contour to his eyelid as well. So again, this is another, he had a road traffic accident about 10 years ago, and it was repaired by a general ophthalmologist. He's been going from one place to the other. Nobody wanted to touch him because it was a very bad scar on both the upper lids and lower lids. So what we did was we removed the scar tissue from the eyelid, and there was a big defect like this, and so we used a post-articular graft for repair of that defect. And he healed well post defect, but then after that problem was that he had ptosis because of that eyelid graft. So we did a silicone sling because I did not want to do any other technique because it is all very scarred eyelid. So he's relatively okay with now his pupillary margin is visible, so he's happy with the visibility, and cosmetically also is much better than what it was earlier. Another case, the patient came to me about 3 months after she had her road traffic accident. It was operated primarily by maxillofacial surgeons. So they did a bony reconstruction as well. So this is the original fracture that was there, and but the bony reconstruction is not too bad. So there is done a fairly decent job of the bony reconstruction, but they paid no attention to the soft tissue repair. So the soft tissue repair, the eyelid is all over the place, and there is a big scar running all along the face. And what I am guessing is they must have used just a skin suture, and they've not done any layered suturing. So that is why there's a big scar that is coming out. It's quite intimidating to see that such a big scar in the eyelid. And what we did was we did a multiple WB plasties. I was not sure it would work, but we did some scar modulation, did a lot of scar modulation, and also we repaired the eyelid and put it back into position so that it's aligned properly. And immediately after, this is after multiple surgeries, we had to do about 2 or 3 surgeries to get her to this position, and then of course we always do the scar modulation immediately following the surgeries. And this was at the end of the surgery. So at end of the scar modulation, of course it's a work in progress. Still there is some amount of lateral canthal dystopia, which we want to correct in the little future. But we want to give her a little time. She is not very ready for another surgery right now. So this is she's fairly happy with what we have achieved now. But the surgeon in me is not happy. I want to do it a little bit better. So in summary, primary and early reconstructions will give best outcomes. So eyelid reconstruction is a specialized job, best left to oculoplastic surgeons. And oculoplastic surgeons as a society, we should establish some credentialing process so that not everybody is able to do it, and there's some accountability for the outcomes. And we need to, in such cases when they come to us, we have to speak to them and listen to them. And the expectation needs to be moderated, because the best we do also may not be enough at that time. So even, and also surgeon and both the patient have to take those small wins when we do get what we are trying to achieve, but we may not get the big wins all the time. Thank you very much. So now that we've finished our presentation, we still have some time for our 10 minutes time for a panel discussion. If you have any questions, please feel free to, please there's a mic there at the next, you can.
Regarding,
It's not, yeah, you can use this mic, sir. That mic there.
this is regarding dog bites.
Yes.
They are in very high risk group.
High risk?
Group.
Yes.
And how do you manage that? Like, and there's rabies serum, etc. and everything.
So there was this papers that had come out that we would give a 48-hour window.
Okay.
For the before we start the reconstructions.
Okay.
The place where I worked also, the pediatric department was stressing on that we should give a 48-hour break before we start the primary reconstruction, because the chances of rabies virus getting into the bloodstream is very high if you do a primary suturing. But there is no evidence that this happens as such. So we have convinced our pediatric to do that. They do the rabies immunization as per the protocol that we have for the dog bites. So dog bite, there's a proper protocol that is mentioned on that, and we also give intraoperative as well, intraoperative immunoglobulins as well, along with the IV immunoglobulins. So at the same time we do it, and we are so far we have not had any cases of rabies post surgery, but of course it's the incidence of rabies will be very small because of all the awareness of the anti-rabies serum availability is also good. So right now we don't have that 48-hour window between the, so we have convinced our pediatric department to straight away go ahead with the emergency surgery.
Okay, you do directly take up for primary repair.
Sorry?
You take up directly for
Can you
primary
hold
repair.
it? We can hear you.
You take up directly for primary repair.
Yeah, we take it for primary repair. We don't wait it because sometimes even 48 hours there's some amount of fibrosis that sets in, and it's a little difficult sometimes to, especially the small kids, because the distances is very, the skin is also very tight. So we don't want to wait for those cases, especially in these very large defects. If there's a large laceration, it's better to do it early rather than late. And but we do all the immunization part of it. We don't interfere with it. It's the same protocol.
As per the protocol.
Sorry.
As per the protocols.
As per the protocols, we go ahead with the immunization for all patients, not just dog bites, even dog scratches, cat bites, monkey bites. So even those also we do a rabies vaccination.
Thank you.
Yeah. And by the time any burn patient gets to me, it's already too late. So I had this magic. It's called a rule of 3, but it's not exactly like it's like not dogmatic as such. But usually they are already beyond the 3 months. I think the chances of fibroblastic activity is already dead. So, but there might be some merit to starting it early in the phase, as the patient is healing, so that the subdermal, the subepidermal scarring is much lesser if you use it under the and you can even use in the soakage itself. You can put the 5FU in the wound, because most of you can use it as a soakage material as well. I mean soakage solution as well in the thing. So that will reduce the amount of scarring that can happen.
Okay.
And it also well tolerated in the 5FU is well tolerated on the ocular surface, better than all the MMC.
Yes. Anyone else has an experience like this?
Sorry?
Anyone else in the panel
Yeah,
has some
please,
experience?
if anyone else has some experience with 5, Dr. Ganga.
Questions are common. We don't always get it right the first time because you're not
Dr.
the.
Ganga, a little close, yeah.
We don't always get it right the first time because oftentimes they're managed by somebody else. To address your particular question, one of the things which has not been addressed here is the concept of autologous fat transfer, the microfat and the nanofat transfers, because they have stem cells within. So any bad burns, especially come toward the subacute or the late stages, before you embark on any aggressive surgical reconstruction, repeated autologous fat transfers, and fat is almost always available at any situation, before you do any kind of revision surgery is what we would recommend. Acute stage is a different thing, but this is chronic.
And
Maybe I just
Kasturi
wanted to
also spoke
to make a comment on this. Number one, all of you are ophthalmologists here, right? How many of you are members of the Ocular Society of India? 1, 2. That too, the youngsters. That gives us a lot of hope. The point I'm trying to make is he made a beautiful comment about how societies should start regulating in terms of credentialing. Advocacy also comes in. So dog bites, we see children dying in India from dog bites, dog mauling. It's a pity that's happening. That's where the role of trauma society comes in. That's why you joining the society first, then being the voice, putting together all these cases and asking people to regulate street dogs is, I think, something very important. Sorry to make a political statement. I think that's where we become advocacy experts rather than just managing lacerations. I know it feeds us, but I think we are the one specialty where we are working towards preventing all of these. You guys should take it up.
Another thing about the scars thing, the burn scars, actually, Dr. Kasturi was mentioning about, she was using plasma, fresh plasma of the autologous plasma to help for healing, because it has a lot of these growth factors and stem cells. So she is having some good results with it. I personally have not used it, but that could also be one of the options for burn patients.
May I add something, Raghu? Your presentations are, as usual, treasure trove of information, and kudos to you. Going to that point, I work with a plastic surgeon who deals with a lot of burn, and she does use platelet-rich plasma, infusion injections in the burn area. About that child you had shown who came for the secondary surgery, with the long forehead scar and the eyelid dragged up. What I've seen in my experience is that in children who are coming for secondary surgery, pigmented skins, it's probably, we always take a larger than required graft, but we have to probably go a bit max out on that more, because they invariably end up with a lot of other scars in that time.
Yes.
And there's another question I wanted to ask you, but I blame it on my age. I've forgotten. If I remember, I've forgotten the question. Okay. If I remember, I'll come back to you.
Sure. We still have some time. We have a few minutes. Please, sir. Yeah, I can't hear you.
Hello. Lovely. It was a wonderful talk. It was very educative. All of you are wonderful. Absolutely brilliant slides and photographs. I had a little question is about the 5FU. What is your starting criteria and end criteria?
In sense, when we start?
What criteria do you consider when starting 5FU? And what is the criteria of your end point of usage of 5FU and transcendental combination?
5FU, we usually, the younger the patient, the threshold is lower for me to go for 5FU. The older patients, they heal better with just the regular good suturing. They heal better. And especially these macerated wounds, these patients who come with very bad scars, with tissue loss, and you are trying to salvage whatever skin is there, those patients are the candidates where you would go for early use of 5FU. So I usually start at 3 weeks from after the surgery is done. Okay. In many of these patients, especially the children who are able to take the local injections, I start at 2 weeks itself, because their scarring process starts early. So I use a prilocaine cream to anesthetize the skin, so that they tolerate it better, the injections are tolerated better, because you have to give multiple injections. So many of the kids are okay with that treatment protocol. And we end it, basically it's a clinical judgment. So sometimes we give for 2 or 3 injections and we see how the response is. Then we wait for another couple of weeks, we give a holiday in between, wait for a couple of weeks, and then proceed with another. If we feel that it is benefiting, if it's improving, then we give a few more if necessary. If we feel that it's not changing much, because we've given that 2-3 weeks of gap after the last injection, we are seeing that it's not changed much. Of course, we take photographs every time they come for the injection. So we see that it's not changed much, then we stop at that. So,
even if it's an adult with hypertrophic scars and maybe keloids, would you consider starting them earlier?
Yes, yes. Those who have already, especially those who already have a keloids elsewhere, they're more prone to having a hypertrophic scar. So I would start those patients early, and I would advise them. And many of these trauma patients, because the skin, the epidermis, even though it heals back, the quality of the epidermis is not that great, because it's sitting over the scar. And that's why we should not give any of these injections into the scar, because that actually breaks up the scar and breaks up the epithelial. So we've had a few cases where residents have injected into the scar, and they've come up with an ulcer on the scar area itself.
Thank you.
Maybe I can add to that a little bit. Patients of African origin are very prone to scars and keloids, so I would also start relatively aggressively for them. And patient, of course, presents very early, it's not a question, but if the patient presents at about 6 weeks or 4 weeks or something like that, you go in, or depending on the kind of bad suturing that is there.
Usually around the, if it's very early, like in the 3 weeks or 4 weeks, I wait for them to settle down because I want the inflammation, the scarring to settle down. But at the same time, I do some scar modulation at that time itself, so that it's easier for me to do it at the end. Like this revision is easier if we do the scar modulation very early. But if it's already past 6 weeks or past 8 weeks, usually most of the healing is done. So in those cases, I wait for a few more days, a few more weeks, just to see if it's changing. If it's not changing much, then I can go ahead with the revision as well.
I'd just like to mention that in Caucasian skin, the hypertrophic changes come early, and then we start early. So we start as early as 4 weeks, and we use the silicone gel more.
Correct.
And it really works well.
Yes.
But you have to be sort of diligent with it.
Yeah, diligent with it, and you have to tell the patient to keep the gel on. What they do is they do the massage. How the silicone gel works is because of the pressure.
And
so
it
when
gets
you
into
massage
the
it,
scar.
it pushes the scar in. So if you do the massage, and then wash it off, then there is no effect of the gel. So it has to be kept on, and they should not wash it off after. They should wash their face first and then do the massaging. And just keep that silicone gel on, and do it diligently at least twice a day, more the better. And we have to be very careful that the silicone gel, if it goes into the eye, it can cause very bad chemical conjunctivitis. So you have to tell the patient to be like, it's very small amounts we have to use, and not to smear it over the eyelids so that it will cause the chemical conjunctivitis.
I remember what I wanted to say, Raghu.
Yes.
Actually, as Dr. Sundar was saying, that we should use this forum to advocate safety regarding dog bites. I think
concomitant with the canalicular avulsion, right?
Sorry.
The problems we face are patients who
Closer to the.
Closer. I'll come closer to you.
No, closer to the mic.
Okay. So one of the main issues is with the avulsion injury. Right. The entire lid getting ripped off and hanging by a tag in one corner of the eye. So reconstruction, when they come to you for a reconstruction, that's great. But what happens is we also see patients who had a reconstruction elsewhere, and they come with this huge boggy conjunctival prolapse. How do you manage those?
Conjunctival prolapse.
Prolapse, yeah.
So I think many of that conjunctival prolapse, there's some amount of lymphedema also, because the scarring goes along that, and that they have not managed the scar well, and some of the lymphedema also acts like that, because that's why it everts out as such, and then you feel that there's a congenital prolapse. But some amount of it is this thing as well, like there's some lymphedema. But basically, I think what would help is that we remove the scar line. Once we remove the scar line, the lymphedema settles down, and we resuture it where it's supposed to be resutured, and resuture it where it's supposed to be there, reposition it. Some amount of the conjunctival the prolapse or the edema still remains, but that will eventually go off with the good massaging, and the lymphedema, basically you take it out slowly. It takes some time, and I have also seen that the scar line, if we use, especially if you have a lymphedema on the lateral canthus, suppose. So like there's a scar here and there's a lymphedema here. If we give 5-FU along the scar here, the lymphedema actually resolves because it helps reduce the scar.
Okay, thank you.
Okay, I think, one last question, because I think we're running out of time.
Just to answer, talk about Anirban's issue. What I've seen in these patients, this exposure actually, brings you to a vicious cycle.
Correct,
so it's
correct.
important that kind of situation to initially go for a temporary tarsography, get the conjunctiva in, let it settle down, and then it will go by itself.
And also we can use some phonics forming sutures as well with protein.
Yeah, but you have to actually ensure that the conjunctiva is not exposed anymore.
Correct. So if you pull it down from the fornix, you can put some sutures, and that will. Yeah, and then we go ahead with the revising later on.
May I just add one thing? You mentioned avulsion injury and the lids hanging by a small pedicle. We have to try and reposition tissues as much as possible, and just wanted to add that devitalized tissues, unless grossly devitalized, one has to try and preserve tissues as much as possible, and debridement should be limited in those cases as well.
Yeah, thank you. Thank you for staying back for the discussion. It was a wonderful audience, and thank you all for being part of this course.